This presentation is a brief overview of the use of Proluton, a synthetic progesterone in the field of obstetrics. We will first introduce Proluton and review how it can be applied in obstetric conditions. We will also go over current guidelines and conclude by discussing its safety profile. This is a flowchart of our discussion. What is Proluton? How does it work? Proluton, or 17-alpha-hydroxyprogesterone caprate, is a synthetic progestogen. It is manufactured by the esterification of a progesterone metabolite, which increases its progestogenic activity. It is also known as hydroxyprogesterone hexanoate. In order to understand how Proluton can be used in obstetrics, it is important to understand the role of progesterone in pregnancy. Progesterone induces changes within the lining of the uterus to allow the implantation of a fertilized egg. It then prevents rejection of the embryo by immune modulation. It also prevents the contraction of the uterus by suppressing contractile genes, inflammatory mediators, and oxytocin to prevent uterine contraction. Progesterone exerts its effects on the cervix as well. Effacement of the cervix occurs through reorganization of collagen as well as inflammation, and these events are affected by the various enzymes and proteins shown on the slide. What progesterone does is to prevent collagen reorganization and inflammation by inhibiting and upregulating proteins to maintain cervical competency. With that in mind, we can see how Proluton, as a progestogenic agent, can possibly help with various obstetric conditions. In this presentation, we will focus only on preterm labor and short cervix. Preterm birth is defined as delivery at less than 37 weeks. In the US, the number of preterm births have been on the rise and was reported to be 12.5% in 2004. This has resulted in over $26 million in cost. Despite medical advancements such as Proluton, which was introduced in 1970, prematurity rates continue to rise. One of the reasons is due to having only 25% of obstetricians offering it to their patients. The lack of clinical use is mainly due to conflicting results from experimental studies. Let us now discuss the results. While the cause of spontaneous preterm birth is unknown, a history of spontaneous preterm birth is one of the strongest predictors for a preterm birth in a subsequent pregnancy. It is speculated that preterm labors are caused by the breakdown of factors maintaining uterine quiescence, fetal distress, and progesterone withdrawal. In this RCT study by Meyers et al., Proluton was shown to be effective in preterm labor. 459 patients at high risk for preterm birth because of a prior preterm birth was randomized to receive weekly Proluton or placebo at 16 to 20 weeks until 36 weeks. The results were measured using the outcome of preterm labor of less than 37 weeks. Those included in the study have a history of spontaneous preterm delivery between 20 to 36 weeks, of a live-born singleton, and a current pregnancy between 15 to 20 weeks plus 3 days. Those with multifetal gestation and any known fetal anomaly were excluded. Results from this trial showed that use of Proluton significantly reduced the risk of preterm delivery compared to placebo. The benefits of Proluton extended beyond merely prolonging the length of gestation. Of the infants exposed to Proluton, there was reduced perinatal morbidity, necrotizing enterocolitis, intraventricular hemorrhage, and need for supplemental oxygen. Twins are another high-risk group for preterm birth. A randomized controlled trial conducted by Rouse et al. Reported no differences between Proluton versus placebo. Similar findings for triplet gestations were recently demonstrated in another randomized controlled trial. It reported no differences in preterm birth rate across all weeks of gestational age. A second, more recent study by Combs even reported an increase in neonatal morbidity. Thus, no benefit has been found to support using Proluton in triplet gestations. In terms of threatened preterm labor, there is conflicting evidence on the use of Proluton in management. The RCT by Fashionette et al. In 2007 showed an increase in the average time to delivery. However, another multi-centered RCT by Rosenberg et al. In 2012 reported no differences in the average time of delivery with the use of Proluton. Besides these two studies, there have been other research done with progesterone, and they too have not yielded positive results with respect to threatened preterm labor. Finally, Proluton has not shown to be effective with tocolytics in acute preterm labor. To summarize, Proluton has been shown to benefit patients with a previous history of preterm birth and not effective in multi-gestational pregnancies, threatened preterm labor, or as adjuncts to tocolysis. The next potential use of Proluton that we are going to discuss is the use in pregnant women with short cervix. Short cervix has been shown to be an independent risk factor for preterm delivery. A pregnant woman can be diagnosed as having short cervix if she is shown to have cervical length less than or equal to 25 mm in pelvic ultrasound. In treatment of short cervix, there are high-level evidence that cerclage and vaginal progesterone are efficacious in attenuating cervical shortening and lowering the risk of preterm delivery. However, the role of Proluton in this setting is unclear. A secondary analysis of a randomized controlled trial by Bergela et al. In 2010 showed that in patients who have been given cerclage, there is no statistically significant difference in outcome in patients given Proluton. In patients without cerclage, Proluton decreased risk of preterm delivery before 24 weeks and reduced perinatal mortality, but showed no difference in other outcomes, including preterm delivery before 35 weeks. A retrospective study by Raphael et al. In 2011 also showed no significant difference in outcomes achieved by giving Proluton to patients with cerclage. Finally, a randomized trial by Killer et al. In 2009 comparing the efficacy of cerclage and Proluton showed that they have similar efficacy for patients with cervix shorter than or equal to 25 mm. However, cerclage was shown to be more efficacious when the cervical length is less than or equal to 15 mm. Considering the currently available evidence, it can be concluded that in patients with short cervix who have been given cerclage, Proluton did not improve outcomes. On the other hand, in patients with short cervix without cerclage, some studies indicate that Proluton is useful to reduce risk, but only if they also have a history of preterm delivery. However, all the studies done on Proluton in the setting of short cervix only involved a rather small number of patients. There is currently no high-level evidence on the use of Proluton for short cervix. In agreement, ACOG stated that Proluton is not for women with short cervix and no prior preterm birth, and RCOG does not recommend routine use of progesterone supplementation following cerclage. We will proceed to discuss the safety profile of Proluton. Although the FDA lumped Proluton together with other progesterone-like drugs which have showed an increased risk of hypospadias, recent studies have demonstrated that Proluton is safe to use with no evidence of teratogenicity, androgenic activity, glucocorticoid activity, and virilization of female fetuses. According to ACOG guidelines, Proluton usage is recommended for patients with history of a spontaneous preterm birth less than 37 weeks with current singleton pregnancy. Proluton is to be initiated between 16 weeks 0 days and 20 weeks 6 days of pregnancy. RCOG endorses current recommendations that in women at high risk of preterm delivery, progesterone administration should be restricted to clinical trials. The two most recent ongoing multi-centered clinical trials include the following studies investigating the use of Proluton in women with a previous preterm birth and the use of Proluton in women with premature rupture of membranes. Conclusion. In this presentation, we have showed you how the mechanism of Proluton opens up several possibilities for its use in obstetrics, especially in preterm labor and short cervix. We have adequate evidence for its use for women with a prior history of preterm labor, but not for those with short cervix. Thank you.